heartful thanks to Dr. Jyoti Budi, Mr. Vinesh Gadia, and the entire team at 49 for firstly hosting this wonderful scientifically oriented conference, and secondly for making me a part of this particular event. It is always a pleasure to meet and interact with their team. So after Jatin's talk on various stimulation protocols, how do we stimulate patients of different categories, I actually take you one step back and try to share some thoughts on what are we actually looking for when we want to stimulate our patient or when we want to treat our patient. And once we know what we are looking at, we should then have a path as to how we are able to get there. And to begin with, the first thing that we need to define is what is success in IVF. Because everyone wants to be successful. Our whole aim of treating the couples is to achieve success. But do we actually know what success is? Because there are many methods of defining success. You have many numerators and many denominators. You could look at a biochemical pregnancy beta-HCG positive to a gestational sac to a fetal heartbeat to a live birth. You could look at it per woman, per embryo transfer, per pickup, per cycle started, so on and so forth. And based on this, you could give different figures to the couples. And this is a classic example of how confusing this can be. And let me take you through this scenario. A clinic treats or starts stimulating 105 couples. On an average, 5 of this would get cancelled before egg collection and you would end up with 100 egg collections. Another 5 or 10 would get cancelled because of no eggs, no embryos. 50% of this would get pregnant. 10 of this would end up with a miscarriage. And some of them would have a later loss and you would end up with a couple of live births. Now you could represent the same thing in many different ways. You could say that your pregnancy rate is 55% if you look at a positive beta-HCG per embryo transfer. Or it could be 50% if you are looking at a pregnancy rate per egg collection. Or it could be 44% if you are looking at a clinical pregnancy rate per embryo transfer. Or it could be 27.7% if it is a live birth per embryo transfer. Or it could be 25% if it is live birth per ovum pickup. But what is most important from a patient's perspective is that if 105 patients started treatment, how many of them did achieve their goal of having a live birth? And this is 23.8%. So a figure as high as 55.5%, which is also true, to a figure as low as 23.8% is what the patient is expecting. And this is where I come back to what my previous speaker, Dr. Rajiv, mentioned about transparency, because you cannot have an expectation-reality mismatch, and you cannot quote figures which will be really unrealistic, and it is different from what a patient expects. Because you want the patients to come back again and again, because one thing is certain, that higher the number of attempts that the patient has, higher will be the chance of her achieving what she wants for. So what we need is actually thinking in terms of a different definition of success, something which looks at everything in this parameter, and we need to look at what is the cumulative live birth, we need to look at how satisfied the patient is, what is the dropout rate, and what is the adverse effect. But we cannot have such a vague way of defining success. There has to be a standardized format by which success needs to be defined. And today, all international registries define success in IVF as a cumulative singleton live birth per cycle started. And from a patient's perspective, this is the only figure that matters. So from all patients who start stimulation, how many of them will end up with a singleton live birth till we use all the embryos that have been generated from that particular cycle. And this is how we report success in the ICMAT World Report. So ICMAT is the international body affiliated with the WHO. We collect data from registries across the globe, and the world data is reported, and this is how it is being reported as delivery rate per aspiration. So all the pregnancies arriving from that particular egg collection, because this will include all the different parameters, how many patients succeed, how good is your cryopreservation, how good is your patient satisfaction and patient continuity with treatment, how good is your retention. So this is the only parameter that matters from a patient's perspective. So keeping this in mind, that what we are aiming for is cumulative singleton live birth per cycle initiated. Let us see how many eggs do we need to achieve this goal, because you need to tailor your stimulation to achieve this. Now this is an old publication from Shesh Sunkara, where she looked at data from the HFEA for a period of nearly 20 years. And what she showed, that the live birth rates keep on increasing as the number of eggs increased up to 15. Between 15 to 20 eggs, it plateaued, and the moment we exceeded 20, it actually started to drop. But this is the live birth rates looking at the fresh embryo transfer. So this is from an era where the definition of what we are expecting has changed. So if you look at only live births from the first fresh transfer that you are able to get, maybe this is okay. But when we are looking at the cumulative outcomes from all the embryos created from that particular cycle, we need to rethink as to what is the optimum number of eggs that we should be producing. Because we know that higher the number of oocytes that we produce, higher will be the euploid embryos that we will get. So the euploid embryos, the number which we get is a factor of the number of eggs that we produce, and this is true across all the age groups. Higher the number of oocytes, higher is the probability of getting at least one euploid embryo. And your aim of stimulation is to achieve as many euploid embryos as you can get, so that this can give a higher pregnancy rate. Polizos has shown that higher the number of oocytes, higher the number of embryos, higher the number of euploid embryos, and hence higher the number of cumulative live birth rate. Because the moment we start talking in terms of cumulative live births, we are going to use all the embryos that have been created from that particular cycle to give what the patient wants. So the number of oocytes that you retrieve is actually a balance between efficacy on one side and safety on the other side. You need to produce the right number of eggs without compromising the safety for the patient. And the definition of safety or the parameters of safety have also changed with the advent of the antagonist protocol with the agonist trigger, leading to a significant reduction in the risk of ovarian hyperstimulation syndrome. So for the delivery rate in fresh cycle, it increases to maybe 10, 11, because then all the redundant embryos are of no use on the one side, and secondly, supraphysiological levels will actually impair the fresh embryo transfer outcomes. But when we start moving into the cumulative rates, including the fresh and all the subsequent frozen embryo transfers arising from all embryos of that cycle, maybe up to 20 oocytes is what we are aiming at. And this figure of 11 to 20 is ideal, irrespective of whether it's the agonist or the antagonist protocol. So the first thing that we need to start thinking about is that the number of oocytes that we need actually is higher. There is also thought of what is called the one and done approach. And many times when we start stimulating the patients, you should ask the patient what kind of a family you are looking at. Do you want a one-child family, two-child family, three-child family? Because it is important that if the couple wants a higher number of children, we create the embryos today rather than 3, 4, 5 years later, where she could be facing challenges. So this is what is called the one and done approach. And here again it is believed that if we want to look at producing more than 2 live births from the same attempts, we need a higher number of eggs. So the first thought that I would like to share with you is that we need to be optimum in our stimulation. I don't mean that we should go completely wild and we should just overstimulate our patients, but we need to be sure about getting the right or the optimal or the possible number of oocytes that we could get from that one stimulation of the patient. Because remember, in the entire IVF process, ovarian stimulation and egg collection are the riskiest parts of the process. Most of the complications that you will encounter are because of stimulation related problems, hyperstimulation, or because of the egg collection in the anesthesia. Frozen embryo transfer has practically zero complication rate. The only complication of an embryo transfer is multiple pregnancy, which is preventable. Otherwise, it is practically a risk-free process. So why subject a patient to multiple risky attempts rather than doing one attempt, get the optimal number of oocytes, create optimal number of embryos so that she can have a desired outcome. So once we want to do this, the second question that would come to mind is how do we decide what we need for the patient, and do the ovarian reserve tests actually help us in deciding what protocol do we need for that particular patient. Now, ovarian reserve is something which denotes the functional potential of the ovary as to how good the ovarian function is. We should look at this reserve both in terms of quantity and also in terms of quality, because what we need is both. We need higher quantity of good quality embryos. So we need to look at from both quantity and quantity. So it reflects actually the remnant in the declining pool of primordial follicles, and it will also tell us about the reproductive potential of that patient in that particular ovarian stimulation. So this can actually be classified as the true ovarian reserve, which is the pool of primordial follicles which is in the ovary. This is something which is genetically programmed. A woman is born with a fixed number of pool of this primordial follicles. It is gonadotrophin independent. A fixed cohort of this undergoes atresia every month, irrespective of whether she is being stimulated or not. The follicles undergoing atresia do not increase if you stimulate her, or they do not decrease if you don't stimulate her. This is something which is genetically pre-programmed, and this is the true reserve of that particular patient. Some of these follicles every month then start getting committed, and they start becoming gonadotrophin responsive. And when we look at stimulating a patient, what we need is the cohort of gonadotrophin responsive follicles on that day, on the baseline of that particular patient. And this will tell us what she will produce in that particular cycle. So from something which is independent of gonadotrophin, it is genetically controlled. For IVF, what we need is what is the gonadotrophin sensitive. And for practical purposes, we have three markers that we can rely upon: age of the patient, anti-Mullerian hormone, and the antral follicle count. All three denote different things, and let me share this with you. As far as the quality of the eggs and the subsequent embryos go, age is the only indicator of quality. AFC and AMH are indicators of quantity. They are not indicators of quality. This is very important to remember, because when we counsel our patients, low AMH at young age versus low AMH at high age have completely different prognosis, because a woman of low age, young age with a low AMH might produce fewer eggs and fewer embryos, but the quality of those eggs would be good. An older patient at 40 with a fantastic AMH might produce a lot of eggs, but only few of them would be normal. So while a woman of 20 and 40 might ovulate the same number of times in a year, their monthly pregnancy rate would be completely different, because the euploidy and euploidy rates of the eggs and oocytes are completely different in both the extremes. So as far as quality goes, age is the only important predictor of oocyte quality. And we have shown that this is something which is ethnicity driven. The reserve falls differently across different ethnicities. This is where we compared Indian versus Spanish. We have another subsequent publication where we looked at Far Eastern, Indian, Middle Eastern, European and American, and we found huge difference in the ethnicity-driven ovarian reserve. Let us then see what is anti-Mullerian hormone. Now this is secreted by the granulosa cells before they become sensitive to FSH. So AMH is secreted from that cohort of follicles which are not yet sensitive to FSH, and hence it is fairly constant. It is even not suppressed during pregnancy because this is a gonadotrophin independent mechanism which continues in the ovary. What AMH does is it prevents recruitment or very fast depletion of the ovarian reserve pool. So if the AMH is high, it will prevent a large number of follicles to be recruited and depleted. So in a young patient with good ovarian reserve, the AMH is high. As the reserve starts to fall, we want higher percentage of those follicles to be recruited, and hence the AMH starts to drop to allow more follicles to be recruited. So what AMH does is it inhibits the initial follicle recruitment and it inhibits FSH dependent growth. So more follicles, less follicles will enter gonadotrophin dependency if the AMH is high. If the AMH is low, it will allow a higher number of follicles to achieve gonadotrophin dependency. As compared to this, antral follicles are the small follicles less than 10 millimeters in size, which you can see in the ovaries and you count them. So this tells us the supply of follicles which will become gonadotrophin dependent in that particular cycle. And if this number is low, you will expect fewer follicles to be recruited. It is again important for an average practitioner to know that a count of 10 is also low, because many times you are referred patients by doctors who say this is a young patient with a beautiful, I can see 4 follicles on both the sides, and we know that 4 follicles on both sides is below average ovarian reserve. And this is something we need to educate even our referring doctors, because they should also not feel that we are falsely counseling patients about a poor ovarian reserve. So to come back to this, AMH and AFC measure different stages of the ovarian reserve protocol. AMH is a parakine controlled, gonadotrophin independent ovarian reserve, whereas antral follicle count shows the FSH dependent follicles available in that particular cycle. So many times we find that there is a mismatch between the AMH and AFC, and we wonder why is it so. It is very likely that in a patient who has a good AMH, if the AFC is low, maybe the cohort available in that month is low. Give her another month, she will have a better cohort in the next month. So good AMH, checked again, low antral follicle count, maybe that cycle is bad, give her a couple of months, she will have a better cohort coming up. So both look at different things. But neither of these are predictors of pregnancy. They are only predictors of number. They will tell you how many eggs and how many embryos you are likely to get. Secondly, they are more accurate predictors at extremes. If it is very low, it will predict poor response. If it is very high, it will predict hyper response. But in the normal range, it is not a very acute predictor, because you also have the so-called hypo responders. And AMH, AFC will not be able to predict that middle group. And thirdly, what is important from our perspective is the antral follicle count on the second day, and this is the best predictor of the number of oocytes you will get in that particular cycle. And we have seen many times that a patient comes for 2 cycles, you give her the same stimulation, and she produces a vastly different number of eggs in both the cycles. Why is it so? Because the antral follicles available on one particular cycle was different as opposed to what was available in the subsequent cycle. So this is for us the most important predictor of how many oocytes we are likely to get. So with this kind of information, now what kind of stimulation protocol will we use? And I will only give you a broad overview, not go into detailed stimulation protocols. What we need to decide is agonist or antagonist, mild or conventional, HMG or FSH, urinary or recombinant. These are the 8 parameters that we need to define. So how do we down-regulate the patient, with the agonist or with the antagonist? And now we have fairly enough evidence that for an average patient, live birth rates with both the protocols are equal and there is no difference between the two. For isolated cases or from a safety perspective, yes, we have options of choosing one over the other, but in terms of response or quality, both the protocols give rise to equally good number of oocytes, embryos, and clinical parameters. What type of stimulation would you give? Mild, conventional, or intensive? And I've shared with you earlier that our aim is to produce somewhere between 15 to 20 eggs. So in this particular scenario, what is the role of mild ovarian stimulation today? Now, mild ovarian stimulation is defined as a protocol in which we stimulate the ovaries with an intention of limiting the number of oocytes that we are producing. So what we are doing is to converting a patient into a hyporesponder. We are actually converting a normoresponder into a hyporesponder by giving her a low stimulation. And this came from the thought that this possibly gives rise to better quality of oocytes, better hormonal milieu. But we now know, again, as I have shared, higher the number of oocytes, higher the number of embryos, and with the advent of all-freeze approach, where we are able to prevent the risks by freezing all the embryos, we are able to overcome the effect of the supraphysiological levels of the hormones on the endometrial receptivity by segmenting the 2 cycles. What we actually need is conventional stimulation for a patient, which is the right stimulation with the right dose to produce the optimal number of oocytes. Again, another study showing that high doses of gonadotrophins do not produce worse quality of oocytes or embryos. So across age groups below 35, above 35, the rates of aneuploidy and the live birth rates are exactly the same, irrespective of the total amount of gonadotrophins that have been given to the patient. But what is still more important from a patient's perspective, that by giving a better stimulation, even if you produce one extra egg, because the question is what difference will it make if you get that one extra egg? Beautiful study which shows that one extra egg increases the live birth rate by approximately 5%. So even one extra egg does matter. And this does matter when we are looking at, again, the cumulative pregnancy rate. It may not contribute in that particular cycle, but if she has one extra embryo, it will lead to an overall improvement in her live birth. So you give the patient what is optimal, what she needs to produce the best number of oocytes. Agonist versus antagonist does not matter. Mild stimulation, certainly no. Give her the right stimulation. So then the question is, which gonadotrophin would you use? And this is what Dr. Jatin mentioned earlier, that the earlier trend in India was to give FSH for the first 5 days and start HMG or add LH after 5 days. We now have evidence that LH receptors are expressed on the follicles at a fairly early stage. And by the time the follicle is more than 5 millimeters, more than 80% of them have LH receptors. So if they have LH receptors, it means LH has a role. And if it has a role from the beginning, we should give it from the beginning. Again, what Jatin had mentioned, so in the US, if you see, all clinics use a combo protocol and all stimulations have FSH and LH, so a combination of recombinant FSH and HMG, whether it is urinary or HP, it is immaterial. So they always give a combination protocol. The second advantage of this is that one of the ways of preventing or reducing the risk of a hyporesponse is to add LH. But if you use a combo protocol from the beginning, you will inherently reduce the risk of iatrogenic hyporesponders. So there is a thought that a combo protocol for a majority of the patient is okay, except maybe for those who have polycystic ovarian syndrome, very high LH, maybe you don't need to give. And hence, if you look at the evidence comparing recombinant FSH versus HMG, all publications show that the results are more or less the similar, and there is no significant difference in any of the parameters. Even if you compare recombinant FSH versus highly purified FSH, again there is no difference. So the question is it so? Then why this whole debate? Why can't we use the cheapest urinary HMG for all our patients? If all studies have shown that all the drugs are similar, why is there this particular controversy? And this lies from the fact as to how the bioavailability or the biological activity of the molecule is assessed. So for all urinary products, the bioactivity, what you get as international units after the ampule, is measured by the Steelman-Pulley bioassay. It is a very crude method. You inject the test animal with the hormone which needs to be tested. The animal is sacrificed, the ovaries are removed, and the ovaries are weighed. And you see, based on the increase in size of the ovary, which is because of the biological response, you decide on the potency. But this is not an extremely precise way of measuring the bioactivity, and hence it has a coefficient of variation between 10 to 20% for all urinary gonadotrophin molecules. And because of this, all pharmacopoeias will allow a product to be marketed if it satisfies between 80 to 125% of its potential activity. What this translates into is that a urinary gonadotrophin which is marketed as 75 can legally have anything between 60 to 94 international units in it. And this is where the challenge lies. As opposed to this, when you move to recombinant products, these are measured by fill by mass. They are measured in micrograms, and you can see the consistency, it is only 1.5. So if you treat 100 patients, if you give 75 units of rec FSH to 100 patients, few will get 73.5, few will get 76.5. But if you treat 100 patients with 75 units of a urinary product, some will get as low as 60, some will get as high as 94. But if that patient is getting 75, it is as good as the recombinant. Now see the effect when you are moving into IVF and you want to treat the patient with 225 units. So when you're treating with a recombinant product, she will get 15 units plus minus. But if you're treating her with a urinary product, she can get anything between 170 to 270 units. So this is the only problem when you use urinary versus recombinant. It is only the consistency. The efficacy of the products or the efficacy of the molecule is the same. It is only the consistency because of the way these drugs are measured that you have the challenges. So what you should do on the basis of this, first is to categorize the patient. Is she a hyper-responder? Is she a normo-responder? Is she a low responder or a hypo-responder who had a normal ovarian reserve or a reasonably good ovarian reserve, or she has a genuinely low ovarian reserve? And based on this, if you think she is a hyper-responder or a high responder, you would always use the antagonist protocol because you have the safety of the agonist trigger to prevent ovarian hyperstimulation syndrome. You would use a milder stimulation because she has very high number of ventral follicles, so you will be very careful in exceeding 200 or 225 international units. If she is a normo-responder, which unfortunately today contributes a small percentage of patients, here the agonist or the antagonist are equally good, but the antagonist has a slight edge because if such a patient over-responds, you can fall back on the agonist trigger even in a normo-responder. And in these patients, a reduced dose or a mild stimulation is not recommended. You give her the conventional stimulation. And lastly are the various low responders, the four Poseidon groups. And here again, the antagonist and the agonist both are equally recommended. What Jatin had mentioned, important is to synchronize the follicles, whether you do it with the pill, with the luteal estrabate, with the follicular estrabate, with the antagonist, or with the agonist suppression. It is important to have a synchronized cohort when you start the stimulation. And secondly, you need a higher stimulation dose. Most publications will not endorse above 300 international units. Many in India go up to 450 international units. And secondly, these are the patients who need LH, so you give either only HMG or you give a combination of FSH and HMG, and you need to correct the asynchrony. So to summarize, ovarian stimulation and the egg collection are the riskiest parts of the entire IVF process. We should aim your stimulation to optimize the couple's overall reproductive need. Does she want a single child? Does she want more child? How old is she? If she's 35, you do a mild stimulation, produce one embryo. When she comes back after 4 years for a second child, she would have challenges. You start thinking in terms of cumulative outcomes. Don't look at the outcome from the first pregnancy rate itself, because our ultimate aim is to give the couple a healthy child, children from more attempts, not from that single attempt, to a healthy mother with the least burden. And we need to think in terms of medical burdens, financial burdens, and the psychological burden of having multiple attempts. So once again, I thank the entire organizing team for inviting me. It is a pleasure. Thank you very much.
Thank you so much, sir, for that insightful lecture. So, though stimulation protocol, both of you, the legends have covered, but here the physiology was put so well, and the difference between antral follicular count and AMH, which to give more importance, was very well told, the physiology. Thank you so much, sir. So we'll open we still have some 2 minutes. Any questions for sir?
Thank you so much, sir. It was a wonderful lecture. My doubt is can you please once again tell how to correct the asynchrony?
Okay. So if you go back to the physiology, follicular recruitment starts from the late luteal phase of the previous cycle. These FSH starts to rise 3, 4, 5, 6 days before the expected period of the patient. Now in a patient who has normal ovarian reserve, this is not very critical, because even if one follicle gets selected earlier, in a normal responder, you might get one egg less, but you will still get a reasonable number of eggs. As the ovarian reserve starts to fall, this becomes more and more apparent, this becomes more and more magnified. So in a patient, let's say, who has 3, 4, 5 antral follicles, and you have one follicle which has been recruited by the time she reaches day 2, if you then start to stimulate, there will be one lead follicle and the others would be following her. And you do not want that to happen. So you need to prevent this physiology of recruitment which happens in the previous cycle. You can do this by giving the patient oral contraceptive pill, because this will prevent the late luteal phase FSH rise. But in a poor responder, sometimes the pill suppression is detrimental. So easier is to give the patient low dose of estrogens beginning 5, 6 days before her periods are due. So you just give 2 milligrams twice a day, and this will prevent the FSH from rising and recruiting the follicle from the previous attempt. This 4 milligram does not prevent menstruation. It is not detrimental to a pregnancy if she conceives in that cycle, but it will prevent this asynchrony. So when this patient then comes on the second day, the follicles will be more or less synchronous. So the best way to correct asynchrony, in my opinion, today is to give estrogen 5 or 6 days before her periods are due.
Thank you, sir.
Thanks for that question as well. Sir, what is your take on random start, late luteal phase random start for such a experience? We have been doing in 49, maybe around 50 patients we have done, but only problem is to rule out pregnancy and the learning curve of late luteum random start, because now globally, if you see, most of them are even presenting papers on relieve yourself from day 2. You can start recruiting the follicle and start the stimulation, but what is your experience, sir?
So I think random start comes with two different concepts. One, we now know that there is what is called the multi-wave recruitment. So follicular recruitment does not necessarily happen only on the second day. It is almost a multi-wave continuous phenomena happening throughout the cycle. So no matter which day of the cycle you stimulate, there will be a wave coming in and you will be able to latch on to that wave. Having said this, the advantage of the random start is to prevent time. So if time is a concern for the patient, yes, random start is of value. So in patients having malignancies, where time is of paramount importance, yes, there is a role of random start. Or in patients, if there are time constraints because of any other work commitments, yes. But if there is no constraint to start on that particular day, I would still prefer to start it in the conventional way. Because no matter what, it will be a slightly compromised cycle. And especially so if the ovarian reserve is still low, then also it is a challenge. Secondly, random start is not literally random. It cannot start on the day of ovulation. So random is as random as it can be. You could start it somewhere in the mid follicle or in the mid luteal phase.
Thank you so much, sir. Thank you.
Thank you very much.